Can you hear me now? Yeah. All right, I'm going to launch into my talk, which is on hip and knee replacement. And then Dr. Lowe is going to get into the actual aspects of how we can do this in a pain-free manner. So total joint replacement is a very common procedure. In this country, we do between 600,000 knees and 300,000 hips a year. This is increasing every year. All of us are getting older, and most of us are developing arthritis. It's projected by the year 2030 that there'll be well over 3 million knee replacements done every year, and in excess of 500,000 hip replacements. In the history of knee replacement, it started out with using animal parts and with doctors basically making things in their garage. The history of hip replacement is not much different. Nowadays, however, we use computer-assisted manufacturing techniques, and a lot of the creativity that the doctors used in the past in trying to develop these implants has been done in a very scientific method. The modern hip replacement owes much of its design to Sir John Charnley in 1961. This is Sir John Charnley, and he developed the low-friction arthroplasty of the hip, and you see x-rays of that here. The reason that people will consider getting total joint replacement is when all else in the management of their arthritis has been tried and has been unsuccessful. And there are a lot of things that can be done. There are a lot of pills that can be taken, there's physical therapy, but when it comes around to the patient's quality of life, and when there's nothing else that is successful in maintaining that quality of life, then we usually will recommend they consider joint replacement. Now, these non-surgical alternatives involve modifying your home with elevated toilet seats and with chair lifts, but in addition, we can use bracing, different kinds of medication, and injection treatments. There are surgical treatments short of joint replacement that are also available. The osteotomy, which means changing the angle of a joint, is also available for both the hip and the knee. Arthroscopy of the knee and the hip is also a popular treatment, although in the more advanced cases of arthritis, it does not have much of an application. But many famous athletes with early arthritic change have found success with arthroscopy, and Alex Rodriguez is one. There are also partial joint replacements that are available, and particularly in the knee, the Oxford partial knee replacement is a popular alternative when the arthritis is isolated to one side of the joint. So what are the causes that people come to my office? Well, the main reason is wear and tear, which is also known as osteoarthritis. But there are other things that can affect the joint. People that are born with an abnormal shape to the hip, which is dysplasia, can develop arthritis. People that have had trauma, that may have had a gunshot wound or had a motor vehicle accident and fractured, can develop early arthritis. And there are other reasons as well, such as rheumatoid and avascular necrosis, which is a blood supply injury to the bone. So the prevalence, because of all these different diagnoses, the prevalence of arthritis increases obviously with age. As well, the prevalence of arthritis increases with body weight. And in this country, we have an epidemic of obesity, and obesity as an independent risk factor for developing arthritis. Education has an inverse relationship with the development of arthritis. People with higher education levels have lower percentages of arthritis compared with people with lower educational background. And this probably has to do with the type of work that they have to engage in, as well as the lack of knowledge of the appropriate diet and exercise and health care that is important to maintain their health. So when you sum it up, there are many, many millions of people and many more waiting in the wings developing arthritis. It is a very common problem. I have it, many people in this room have it. This is the x-ray of a normal knee on the left and an arthritic knee on the right. When you take an x-ray and a person is standing, you should see a gap, a space between the surfaces, and that is the cushion of cartilage that a healthy joint enjoys. When you don't have that cushion, the bone literally touches bone to bone. Many of us have heard that term, I've got bone-on-bone arthritis. Well, this is what it means. There is no cushion, and that individual will therefore have pain. Similarly, in the hip, on the left side, you have bone-on-bone arthritis. You can see the normal gap on the right side of a healthy hip. Clinically, in the knee, you develop bowing, and we recommend people consider total replacement when none of the other non-operative steps is successful. When we prepare a person for surgery, we take x-rays with magnification markers so that our computer can tell us the sizes of the bone that we are dealing with, and therefore we know the size of the knee replacement or hip replacement we're going to need. One of the most important things is having a well-rested, well-seasoned team, and Dr. Lowe and myself work together very frequently, and I know it's going to be a smooth day when David is doing the anesthesia for me. Likewise, when the nurses and the physician assistants and scrub techs are my, what I call A-team, I know it's going to be a good day. And we have worked together for many years, and this is the way that you reduce variability, you improve the function, and you speed up the actual surgical time. These are the basic steps that are involved with knee replacement, and it basically involves taking off about 4 to 8 millimeters of the worn out surface of the joint and then replacing that with metal and plastic. You can see it from the side here. We cut off that end of the bone and the top of the shin, and we cement the parts in place. These are what the parts look like on the back table. The parts are made of different materials. We have ceramic. This black surface here is a ceramic. It's zirconia. And we also have titanium as well as the plastic. Some of the parts are fixed to each other, and the other parts are mobile. This is the partial knee replacement with a mobile bearing. In the hip replacement, we remove that same type of arthritic worn out surface and replace it sequentially with a socket first, and then prepare the femur and next, and replace the femoral component with this metal piece with a new ball. And so the new hip replacement fits in the same location as the original replacement. The muscles are around it. The bearing surfaces on the hip are also variable. We can use different kinds of ceramic. Up until this past year, we were using a lot of metal on metal. And many of you have probably heard the reports in the news about problems with metal on metal hips. And for that reason, I put a big X on this metal on metal implant. This is something that is developing into a very, very big problem in the joint replacement world. And unfortunately, what had been assumed to be an improvement has ended up being a liability. And these metal on metal hips are actually wearing out faster than the metal on plastic hips. Next slide. This is the newest information on the metal on metal hips, and I direct your attention to the date. This is only 2 months old. This is from the Lancet, which is the equivalent, I would say, to the New England Medical Journal in England. Lancet is a well-established, well-known medical journal, and it talks about failure rates of metal-on-metal hips in their national registry. A registry is a database, and in this country we are developing a registry, but we do not have one. In England, as you may know, they have socialized medicine. They have a national registry, so all of the surgeries are kept in a database. And in this database, they evaluated 31,000 metal-on-metal hip replacements done between 2003 and 2011. And it found out that they have a 6% failure rate at 5 years. Now, in this country, a metal-on-plastic hip lasts 95% of the time for 20 years. So this is a very significant failure rate if you multiply this percentage by another 4 times. That's an unacceptable failure rate. And I would say, in addition, there are metal-on-metal manufacturers in this country, Johnson & Johnson and Zimmer, that have had to pull their metal-on-metal implants off the market because of the failure rates that are developing in this country as well. So this is a technology that was put out prematurely without enough testing, and unfortunately it has led to a lot of suffering. Some of these companies are paying for the patients to get these implants pulled out of their body and have a traditional metal-on-plastic implant put in its place. So that is the most recent information on the metal-on-metal hips. And next slide. And this is the variety of metal-on-metal hips still allowed to be put in the United States. This is the Birmingham, and I am still very concerned about these implants, even though they have not been recalled, because they are metal-on-metal, and there is a growing body of evidence that these metal-on-metal hips can lead to very bad reactions in the body. So that concludes my orthopedic talk. Very quickly, a whirlwind tour of hip and knee replacement. Now, I will turn this over to Dr. Lowe, who will explain how all of this surgery can be done in a much less painful fashion. Thank you.
Hello, can everyone hear me? It's nice to see everyone here. As per the introduction before, my name is David Lowe. Tonight I'll be talking about the new pain management program for joint replacement surgery. And I know what most of you are thinking, who's this, how old am I? And am I qualified to give anesthesia for you guys? Well, a little background about me. I came here about 10 months ago from Philadelphia. I did finish about 5 years ago, and I've been practicing for the last 5 years previously at a very busy orthopedic hospital. I've been a part of probably over 4,000 joint replacement surgeries and providing anesthesia for them. And the key is that experience does matter. And I've hoped to keep on working at St. Vincent's Medical Center and to provide some real change for you guys. What we all do know is, and the reason why most of you are here, is that joint pain is painful. It limits your activity, you have decreased range of motion, and you can't do what you could do when you were younger. And the International Association of Study of Pain in 1979 came out with this definition of what pain really is: the unpleasant sensory and emotional experience associated with actual or potential tissue damage. And what all these roundabout words really means is that pain does suck. And since it sucks, what's even worse is pain after surgery. And when you have pain after surgery, there are severe consequences of it. It prolongs your hospital stay, it increases your risk for hospital readmissions, it limits your rehab, you have lower range of motion after you go through the surgery if you're in tremendous amount of pain. There are increased complications, and obviously patients won't be happy. Historically, pain management used to be focused on loading up patients on morphine. You would just keep on getting lots of morphine. Typically, you would be hooked up to this morphine pump, and you just keep on pushing the button until you felt a little bit better. And this was the one bullet approach, and we found out that this really doesn't work too well. There are consequences of too much narcotics. It makes you sleepy, it makes you nauseous, you vomit, you get constipated, you can't go to the bathroom, and whenever all these things happen, you're not going to want to participate in rehab. And the key is that you need to participate in rehab. What we found out through research and trialing all these things is that the key is to attack pain in all different ways. And what they called it was, they titled it Multi-Modal Pain Management. And what this is that we brought together all different aspects of people who are going to treat you. Surgeons, the anesthesiologists, the nurses on the floor, the physician assistants that help out the doctors, the physical therapists, and pharmacists. And what the goal was is to maximize pain relief and minimize all the side effects of medications. And the basic principle behind this is more of taking, instead of using the one bullet approach, taking a shotgun and attack pain in multiple different ways. What we would do is take multiple different types of analgesics or drugs and use smaller doses to attack the pain in different ways. And this is just a brief slide of how actually pain works, or how you sense pain. A red button. Okay. So this down here is just would be your hip or your knee or wherever you would have pain, and you would sense pain from the outside nerve receptors, and then it will travel to your spinal cord and then to your brain, and then that's when you feel it. So all these different areas, the peripheral nerve receptors, the spinal cord, the brain, are all different areas where we can actually target and give different medications or treatment options to target pain. This is one of our patients on the rehab floor. He's actively participating because we came up with a good protocol in terms of treating his pain. And this all starts off with all three different phases, right from the start, preoperatively, intraoperatively, during surgery, and afterwards. The first step that we've instituted at St. Vincent's Hospital is the pre-op joint class. And this is offered through the hospital. It's a 2-hour class, and it's going to go over the entire experience in a classroom setting. So that's a little bit, it's outside the hospital, outside doctor's office, in the classroom, so it's much more informal, so you can ask questions, go over what is going to be expected out of you guys and what you guys are expecting for yourselves. I believe there are nurses there, there's a physical therapist and physician assistants for you to ask questions, and other patients that you are going to be going through the same exact experience as you guys are. Step 2 is based on the principle of preemptive analgesia. And what that is pretty much getting ahead of the pain. And what we found out is that if you start treating pain before it even starts, it decreases the amount of pain you actually feel. If you treat it before, there's a decrease in the amplification of the post-op pain. And what we started probably about only a few months ago is that once you are admitted to the hospital, and after you meet your anesthesiologist, you're going to be given 3 different pills. And these pills are listed over there: Tylenol, Lyrica, and Celebrex. And most of you probably know 2 out of 3 pills. But these are a mixture of anti-inflammatories and pain medicine that's going to start before even making a surgical incision, giving you pain relief. Step 3 is the anesthesia for the surgery. This is where probably a lot of you are going to be frightened of. And what we usually typically do is a spinal anesthetic, which is a small needle stick in your back, which is going to help block the pain pathway at the spinal cord itself. So this is the second target of active pain relief. And you will be sedated. It usually only takes a couple minutes to do. It's a very small needle stick in your back. And what's going to happen is that you're going to be numb from about the waist on down for about 3 hours. I know most of you are scared, but there are significant advantages of spinal anesthesia for joint replacement surgery. There are fewer complications. It lowers your risk for blood clots. You lose less blood during surgery. It's much better pain control for you afterwards. The next step in the pain management protocol is that your surgeon, Dr. Boone, would inject a mixture of medications, including local anesthetics and anti-inflammatories, right into the joint. And this would be done right during middle of surgery or towards the end. The big advantage of this is that it targets exactly where the operative site is. So, and also it's performed while you're under anesthesia, so there's not much pain involved while you're getting it done at all. And then the next step is the femoral nerve blocker catheter. The nerve blocker is another tool that we have that blocks the pain. This is only for knee surgery. And the reason why it's only for knee surgery is that with the hips, which is a little less painful, so we have something in addition for the knee surgeries. This is just a small little needle stick on the side of your hip, and it provides pain relief for the front part of the kneecap. And this front part of the kneecap is probably about where the majority of the pain is. What it involves is we use state-of-the-art technology. We use a high-definition ultrasound to look for the nerves to supply that front part of that kneecap. And what we do is we take a small little picture of the nerve, and we stick a needle. We use the ultrasound to guide it right over the nerve, and then we start injecting drugs right around it. It provides great pain relief. It allows you to be a lot more awake, take a lot less narcotics. There's less nausea, less hypotension, which is low blood pressure. And then it also decreases your risk for urinary retention, which is unable to use the bathroom. And after the surgery, we hook up a little ball, which is a pain ball, that gets connected to that nerve catheter to give some medications for about 2 days. So it stays in for 2 days, where those first 2 days are where the majority of your pain is going to be. That's when the most of the swelling is going to be, and it provides great pain relief during that time period. So in summary, what we're going to do is use we're going to go through the 5 key steps to target pain early and at different sites in order to provide good pain relief for you to encourage rehab and a fast recovery. That's it for tonight.